Brockport, SUNY, and she there is the Director of Field Education for Social Work Department. And she's also the Director of the College of Brockport Center for Excellence in Gerontological Social Work. Professor Fario coordinates the MSW Graduate Certificate Program in Gerontological Social Work and is developing continuing geriatric education programs, both for students and also for healthcare professionals. Her research interests include field education, scholarship of teaching, collaborative interprofessional geriatric assessment models, and international social work education. Deborah serves on a number of professional and advisory boards, including the National Advisory Board of the Council on Social Work Education's GeroEd Center, and CSWE's Field Council. She's also on the State Society on Aging and is a member of New York State's National Association of Social Workers and linkages of Rochester, New York. Deborah serves as a licensed clinical social work, and her clinical and administrative practice is in the areas of gerontological and medical social work. So we welcome you, Deborah, today, and thank you so much for speaking with all of us today on interprofessional geriatric assessment. Thanks, Deborah.
It's my pleasure to join you today. My phone is ringing. I'm going to hang up. Thank you so very much. It's such a pleasure to be invited. The presentation that I'm going to present today is really based on a collaboration with one of my colleagues, Dr. Thomas Caprio. And it's based on some work we have done together in terms of preparing different members of interprofessional teams in geriatric assessment through the work we do in our geriatric assessment clinic. In the chat box, you're going to actually see a link to a free training, and I'll talk a little bit more about that later, on geriatric assessment that's really meant for physicians, for nurse practitioners, allied health. There's a module specific to social work, but that's a resource that we've been using to train nurse practitioner students, geriatrician fellows, as well as my social work students. So, and it has all the different tools that are used in assessment for geriatric assessment. So the students have actually found that pretty useful. Today we're going to focus on describing the core dimensions of geriatric assessment as a model, understanding the roles of an interprofessional team and an interdisciplinary team. Sometimes those terms are used interchangeably. Really focusing on understanding the loss of function and establishing a plan of care in the geriatric population, and gaining knowledge in terms of thinking about ways to integrate interprofessional education in clinical settings. So I'd like to start off by introducing you to Martha. Martha is a 92-year-old woman. She lives alone. She was widowed 14 years ago. Her daughter lives locally here in Rochester, and her son lives in Arizona. She worked for 15 years as an executive secretary for Eastman Kodak Company when Eastman Kodak Company was one of the major employers for Rochester. And Martha is a composite of many of the patients that we see in the geriatric clinic. She is active in her faith community all of her life, has been less active for the last three to 4 months since she's been having some health care challenges. And her social history reflected that she also was volunteering to read at a children's program in her local library, although upon further additional information from the family, it sounds like she really hasn't been quite as involved in that activity for the past year. She has multiple health issues, cardiac problems, pulmonary, diabetes, she has arthritis, and she also has been hospitalized for shortness of breath and chest pain twice in the last 3 months. So for some of you, I'm sure you're already beginning to have some questions about things that you might want to assess in terms of Martha's situation. Martha was functioning pretty well at home. She really had no involvement of support services other than her family until this acute incident in which she fell at home. She was found by her daughter on the floor. They had talked the night before, and her daughter had stopped by her house in the morning to just see if she needed anything before she went to work. And she immediately called the paramedics, and they found that she had right leg pain and was unable to walk. so the paramedics did take her by ambulance to the hospital. And sure enough, she was diagnosed with a fractured hip. And you can see where that fracture occurred. She did have surgery, and second day post-op she developed shortness of breath, worsening shortness of breath, complaints of pain, nausea, and constipation. Well, she certainly had a longer course of hospitalization than what was originally hoped, and upon discharge, she was discharged to a skilled nursing facility for rehabilitation. And what the documentation reflects is that she was very fearful of falling, and she was having a hard time using the walker. She was kind of picking up and carrying it, not using it properly, and her fear of falling really seemed to be pretty disabling to her. She was in the rehab unit for about 4 weeks when the staff was beginning to talk about discharge planning and the progress she was making, and her family, and particularly her daughter, expressed concern about her returning home alone. The daughter reported that she had a history of memory problems, and she had also had several falls at home without injury. The daughter was also concerned about how she was taking her medication, and she reported that she was always wearing dirty clothes and didn't seem to see when her clothes had stains on them. The staff reported that she was pretty cognitively intact. She had some minor memory challenges. She was repeating stories, but she was competent, and Martha's desire was to return home. And so, wanting to support her wishes, also hearing from her daughter, the decision was made to discharge her back home after 6 weeks with Meals on Wheels. She was going to have a visiting nurse service come in, or community health nurse come in and monitor her, maybe and aid a couple of times a week to help with bathing. The daughter was going to stop by every morning just to check on the medications and make sure they're received properly, and it felt like a pretty good discharge plan at the time. As you can see from her home, she lived in a single-family home, although it was out in the suburbs, and so the daughter was now talking to Martha about not resuming driving. Martha had driven, but the daughter did have some concerns about her ability to drive, and mentioned that she doesn't always see as well as she used to see. So 2 days later, her family brings Martha back to the emergency room. She had increased confusion. She was not eating and drinking. She was found on the floor. When the daughter found her, she had received the Meals on Wheels. As the last time, she was seen middle of the day, and the daughter arrived the next morning again to make sure that she had her medications, and found her on the floor. So she was confused. She certainly hadn't eaten or drinking during that time period, and she was beginning to get some breakdown on her skin. Likely had fallen shortly after the meals were delivered, and was just in that position for most of the day and most of the night. She was admitted to the hospital, this time with a diagnosis of pneumonia, dehydration, and failure to thrive. So, I'm sure you're beginning to think about what the next steps would be in terms of management for Martha, and also thinking about maybe some ways that this outcome, this rehospitalization, could have been prevented. And in terms of thinking about geriatric assessment, the kinds of questions we would begin asking about would be thinking about really understanding what really was her prior level of functioning at home. Did we really have a good enough picture of what that was? Do we really understand what the rehab course was in the nursing home? In terms of her hospital management, initially when she went in for the hip, fixing her broken hip, and then the hospital management now in terms of what course might need to be taken to really assess her. And is this being done in teams of silos, or is this being done in terms of really a holistic team looking at her and all of her strengths and all of her challenges? You might be thinking about what are both the cognitive and psychosocial strengths and challenges that she's presenting. We have some information that the family has noted some memory decline, but we really don't have a lot of information about what really that is and what her functioning is, other than when she was discharged from the rehab facility, the staff felt that she would do okay with the discharge plan they put in place. We have a bit of information about the family caregiving. We understand the daughter stops by every day, but we really don't understand what her level of involvement is overall, how that level of involvement impacts her life, if it's a burden to her, if she does it in a way that is very willing. We don't know what their relationship is. We also don't have a lot of information about the interface with the formal care system, and how often Martha, for example, saw her primary care physician, or if there's other interfaces that she had with the formal care system, although we know prior to her hip fracture, she wasn't receiving any formal services. So why is this important? Why is it important for us to think about geriatric assessment and thinking about Martha as our composite for many of the patients that we work with who are over the age of 85? And you know, we sort of all have seen this slide before in terms of our aging population, but really thinking that this is a huge issue for us demographically in terms of our as the age increases, the 85 and above, and that more and more we're seeing older adults as patients and clients in all healthcare settings, and often having a complexity of needs, a complexity of issues that they're presenting with. And truly seeing that complexity and being able to tease out what those issues are often is best done by an interprofessional team. So, you know, these are the kinds of places, right? The kinds of service providers that we know that elders are interfacing with. Certainly even at home, independent in the community, they're going to the bank or they're going to their primary care physician. We have elders with formal home care systems, both living in independent and senior housing, assisted living facilities, adult care facilities, nursing homes, certainly going to rehab centers more frequently. Situations like with Martha's in and out of the hospital, and also thinking about the sort of the community retail providers such as pharmacists that older adults are interfacing with. So there's lots of opportunities to think about how perhaps we could have intervened in situations like Martha's at different levels. So in terms of thinking about the challenges that older adults experience as they age and thinking about the role of geriatric interprofessional assessment, I think one of the things we really want to focus on is loss of function. So really thinking about, is there a level of disability that's being created by loss of function? And at what point does that loss of function become a disability? You know, how are people functioning across their lifespan that there's some kind of crisis such as this fall that then creates a disability? Also thinking about comorbidities, those chronic medical conditions that often create all kinds of additional challenges in terms of medical management, in terms of how the team is working together. Also thinking about being vulnerable and being frail. For example, you know, we really don't know much about how Martha was presenting in terms of her gait or her stability. We don't know if her home was ever assessed in terms of risk for falling, whether or not she has proper lighting. We know she lived in a single family home, so likely there was less chance of falling from stairs, although she may certainly have a basement, we don't know. But thinking about frailty and vulnerability is important, and also thinking about the compounding effect of multiple losses. I think the ability of an interprofessional team in terms of identifying those aspects of challenges that older adults experience provides us an opportunity to look at multiple ways of early intervention. So why is assessment important, in particular an interprofessional assessment? Well, the goal really is to decrease disability and dependence, to identify those preclinical disabilities. It's recognizing that the majority of older adults live independently, they want to live independently, and yet the longer we live, you know, we also know that there's an increased risk of nursing home placement, at least for rehab, and that statistic has changed over time. So one of the things that often gets overlooked in assessment are assessing for those geriatric syndromes. And this is really key for not just the physician on the team, but all members of the team, nursing, social work, the therapist. It's really thinking about the geriatric syndromes as broad categories of signs and symptoms that are common in the geriatric population. So for example, vision impairment. You know, we know that Martha at one point was driving, maybe she's not driving as much, But, how is her vision? The daughter had expressed concern, for example, that she was wearing clothes that were dirty. Could she see those stains on her clothes? We know that she was volunteering reading for children in a library program, so she was able to read, but we also know she hasn't been quite involved in that for a number of months. So what are the ways in which we incorporate vision assessment or asking questions about vision as recognizing that that's part of a normal changing that occurs in a geriatric syndrome. Hearing loss is another example. Simple interventions such as doing a whispering test might be an intervention that different members of the team can use. Certainly assessing for incontinence. If somebody, for example, an older adult, especially women having stress incontinence, that might result in increased isolation and less engagement in social activities because they're afraid of having an accident, for example. Falls and mobility are huge issues in terms of elders and really having an impact in terms of quality of life and actually length of life, right? Depression and also memory disorders. So these common geriatric syndromes, these common categories, these signs and symptoms that are common with older adults, we really do need to pay attention to. We also need to think about the kinds of teams that we work on. So for example, many of us work on multidisciplinary teams, and that term multidisciplinary, interprofessional, sometimes are used interchangeably, but sometimes the multidisciplinary teams that we work on are rather siloed. And I imagine for Martha, when she was being seen in the hospital, that she may have been working with a siloed multidisciplinary team in which a lot of the communication was through the medical record. Folks were focusing on their own scope of practice or their own domains of expertise and communicating with each other, but not necessarily collaborating with one another in a true interprofessional manner. So defining interprofessional collaboration and thinking about teams in terms of interprofessional and really thinking about this idea of collaboration is one that I think we have evidence works. So interprofessional collaboration is a partnership, and really focusing on the partnership. So it's a partnership between a team of health providers and the client. So that's important, right? We talk a lot these days about person-centered work, but so thinking about how do we partner with each other, how do we partner with a client in a participatory, collaborative, and coordinated approach. And that really does require shared decision-making around health and social issues. That sounds wonderful, but it sometimes doesn't occur in our systems of care the way they're organized. So in terms of thinking about interprofessional collaboration, there's some practice principles that need to take place. So it's a process, certainly, and it reflects on the ways in which we develop ways of working together that are integrated and are cohesive to answer the needs of the client and family. So it's also remembering that the family is part of the client system and when we're working with elders. It involves continuous interaction and knowledge sharing between professionals, and it's really organized to solve or explore care and social issues while seeking to optimize the patient's participation. Again, some of our current systems of care in which there's such time pressure to see patients in a primary care office, for example, or even in a clinic setting, often precludes these kinds of principles being put into action in meaningful ways. So the benefits that we know of, and the research demonstrates, is that interprofessional approaches to health and social care are linked to improved clinical services and enhanced problem solving. So there's reasons why we want to really focus on this and think about ways that we can incorporate perhaps payment structures that recognize the value of interprofessional teams. The characteristics of effective collaborative interprofessional teams are several. It really is a belief that the team is important, and that you're really focusing on the role of the team, the value of the team, as important to the outcome. So it has a flat structure versus a hierarchical structure. There's open communication, equality of resources, respect, shared decision makings where all members feel valued. And teams that can function this way, in which people really truly respect each other, and the different lens that each team member brings to a situation without a sense of a hierarchy, really encourages, I think, the opportunity for creativity, as well as the opportunity for each member of the team to stretch each other, right, in new ways, and that can really be quite wonderful, and that's where the collaboration occurs. So in terms of geriatric assessment, it is a method to identify problems and challenges early on, and the earlier we can identify challenges and problems, right, we can better maximize our goal of maintaining and improving function. So it really is a functional assessment in terms of thinking about, even if we're looking at cognitive assessment, it's really about the person's function. A geriatric assessment also provides a screen for common problems of aging, those geriatric syndromes that were mentioned earlier. It also identifies the strengths and resilience of the individual and the family system. It's critical not only to focus on the challenges and the problems, but also to identify what's working for this individual, what's working for this family, how do we build on those strengths to help maximize the independence that's available to them and to support this family system. It's performed by an interdisciplinary or interprofessional team. Again, those terms sometimes are used interchangeably. And the focus is on chronic disease management and effective resource utilization. But both of those are really meant to enhance quality of life. We have, at the University of Rochester, we have a geriatric assessment clinic that was established in 1980, and many of you may know Dr. T. Franklin Williams. He was one of my early mentors, and I was very, very fortunate that back in 1984 I did my MSW field placement in this clinic. And the goals have really remained consistent. The team has expanded, but the goals have remained consistent. There's two goals: maintaining frail older adults in the community at the most independent level of an interdisciplinary approach of comprehensive geriatric assessment. And we'll talk a little bit about comprehensive assessment, because that's really key when you're using an interprofessional approach. And it's one of the main teaching sites for the University of Rochester, in particular for their medical school and other healthcare professional schools in training in geriatrics. And our current members of our team are certainly the U of R, their School of Medicine and Dentistry. They have medical students, residents, geriatric medicine fellows, psychiatry fellows, and dental fellows. The School of Nursing at the University of Rochester, their nurse practitioner, gerontological nurse practitioner students come through the clinic. My students, my MSW students in our MSW program at the College of Brockport, and also St. John Fisher College has a pharmacy program, and so we have a pharmacy faculty on the team, and the pharmacy students participate in the clinic and typically are with one of the attending physicians and geriatrician fellows as they're doing an assessment. So this is what our full team looks like. It's an interprofessional team interface. And while we recognize the professional domain knowledge of each of the disciplines, it's through the collaborative team practices that are central to the model. It really does allow the contextual understanding of very complex issues. So after a patient is seen and a family is seen, and we have a neuropsychologist who does the cognitive testing. Again, we have the pharmacists on the team, nurses, geriatricians, social workers, and we have faculty members from each of these disciplines who are the sort of the mentors for each of the students coming through, but we also model for the other members of the team so that their students are seeing how an interprofessional team can work. But the patient and family is really at the center. And it's really thinking about what are their goals and what is it that they're hoping for, that we really collaborate together in terms of understanding the complexity and the context of the challenges that they're facing. So again, it's a comprehensive assessment performed by an interprofessional team, and again, I'm using interprofessional, interdisciplinary in this context interchangeably. And in our model, after the patient and family is seen, we triage together, we share each of our reports, what we all saw, and then through this team process, we try to get a holistic picture of what might be occurring, what we think the diagnoses are, what are the psychosocial issues, what are the cognitive challenges, what perhaps those are related to, and what are the family stressors, what are the community resources that might be available meet the goals of the patient and the family have expressed. And so we come up with very personalized recommendations, and these are shared with the patient, the family, caregivers, and the primary care physician. This is a consultation clinic, and so everything always goes back to the primary care physician, because they're going to be the ones that are continuing on with the ongoing care of this individual. We also share information regarding community services and agencies to assist the older adults in the greater Rochester area. Again, these are very, very detailed to the specific needs of that elder and their family. So this is sort of, if you were to look at a schematic of our workflow, patients who are age 65 or older, they're either referred by their primary care physician or they're self-referred, maybe from a family member, and they they provide some intake information and scheduling with the receptionist, and then they receive a phone call from the RN on the team who does a pre-screen. They get signed off consents to be able to get information from the primary care physician, and so the primary care physician is always, the PCP is always involved in this screening process in terms of collecting information to begin with, and then providing information back after the assessment. And so when the day arrives that the person arrives to the clinic, they're engaged with all the different trainees from the different disciplines, and the faculty team, and a comprehensive geriatric assessment is completed. And then following the team's triage and developing of a recommendation plan, the patient and family is invited back for a final report and hear the recommendations, and then very formal reports and recommendation plans are shared with the family and back to the primary care physician. So the components of geriatric assessment include medical, functional, psychological, cognitive, social, economic, and family dynamics. If we think about the complexities that we're addressing through an interprofessional approach, one example is if we were to take functional assessment. These are some examples of geriatric competencies that geriatric medicine uses, nursing, and social work, that relate to ADLs and IADLs. And as you see on this slide, each discipline has sort of their own scope or their own lens in which they assess ADLs or and IADLs. And we need to recognize that we each have our own lens, but it's really through the way in which we can work together that the value of each of our lenses really brings it into focus in terms of what the challenges are when we're doing a functional assessment. Another example of the interface of competencies would be medication management. Now, social work's not listed here, but social work also sometimes finds out about, like, the polypharmacy that maybe hasn't been discussed with anyone else. But, you know, again, here medicine, pharmacy, and nursing each have their own ways in which they address the competencies of medical management. But the collaboration with one another, the conversation between team members, really provides a way of really holistically taking a look at medication management that maybe gets the biggest picture, right? The whole picture, based on the kinds of questions we ask that our domains train us to ask, that train us to concentrate on. So in terms of multidisciplinary competencies in the care of older adults, there was a work group that's a couple years ago now that many of you may be aware of, that really looked at multidisciplinary competencies in geriatric. And they came up with 6 domains that different professions need to focus on in terms of competencies in the care of older adults: health promotion and safety, evaluation and assessment, care planning and coordination across the care spectrum, interdisciplinary and team care, caregiver support, and healthcare systems and benefits. And the idea is that we each have our own lens, or have our own way in which we look at these different domains, but there is overlap, and there's benefit by the way in which we can communicate together through this collaborative model of sharing. So in terms of medical assessment, certainly Past medical and surgical histories is important, family history, physical exams, review of medications in terms of polypharmacy, or what we often call in geriatrics bad drugs, drugs that we know that don't do well with older adults, or older adults don't do well with those particular medications. Some of those might be over-the-counter medications. Certainly the assessment of geriatric syndromes that we talked about, such as vision and hearing, incontinence, falls and mobility, memory and mood, nutrition, certainly pain, and also pain management with some of those medications. Review of medications is part of a geriatric assessment in terms of the drug distribution and how that might be impacted by this individual's metabolic system in terms of how that's impacted by or altered by aging. Adverse drug reactions and drug interactions. The number of medications, if you can think about Martha, she was on a number of medications, right? Over-the-counter medications, herbal and dietary supplements that people take, and also sort of those inappropriate meds, the things that can cause falls and urinary problems, delirium that we often see, especially during hospitalization. So really understanding and reviewing medications with an expertise that geriatricians have. Certainly functional assessment and activities of daily living is always part of a geriatric assessment in terms of, ADLs, dressing, eating, bathing, personal care, toileting, mobility, transfers, but as well as IADLs, the kinds of things that people need help with or that we should pay attention to see if they need help with. How is transportation for them? Do they live where there's sidewalks? Do they drive? Do they have access to transportation? Are they able to cook for themselves and cook for themselves safely? Who manages their finances? Are there challenges with that? Is there issues in terms of maybe some folks helping them with finances that may be taking advantage of them? Are they able to manage their housekeeping, their shopping? Who helps with that, and is that consistent and meeting their needs? So paying attention to IADLs, especially as we're looking at the role of family and the kinds of ways that family and friends and other supports and neighbors sometimes can help or can feel a burden by those. We certainly need to assess cognitive dysfunction. Are we seeing normal aging changes? Is the person presenting with a mild cognitive impairment, or do they have a full-blown dementia such as an Alzheimer's disease or a vascular dementia? And it's really important to assess for dementia because we know that with dementia, its behavior is impacted, cognition and function, and it's through the ways in which those things are impacted that often individuals really struggle and families struggle, and so we really need to see that interface and really have some competence in terms of assessing for dementia. Psychosocial issues are part of a geriatric assessment. Understanding the context of who this person is, their social history, presenting their challenges and goals and their perspectives of what those things are, what their mental health abilities are, coping skills, stressors, risk factors, depression screens, a social functioning assessment in terms of social skills, social activity levels, social supports, as well as assessing caregiver needs and caregiver levels of stress. Those are all important. A geriatric assessment can also be dependent upon the context and the location. For example, in the hospital, it may have much more of a discharge planning focus in terms of assessment, in terms of what needs to be done to be sure this person can be at the least can be discharged at the least invasive kind of setting, most independent setting. Perhaps in a clinic and office is a comprehensive assessment. In a nursing home, the focus might be really on improving maintenance, and at home it may be the focus more on mobility and safety. Rehab certainly improving functioning, especially if the person is desiring a more independent level. So we often do functional assessments through our observations. We look at issues in terms of areas of concern, and that may be mobility impairment, range of motion, history of falls, certainly medical conditions such as the diagnoses that of congestive heart failure or diabetes, or the things that we know can cause challenges. Also, I think in terms of core areas, it's looking at rehabilitation, but it's looking at both tolerance and potential, and also the psychosocial components that we discussed. So in establishing goals with older adults, they need to be individualized and patient-centered, really focused on how do we maintain independence longer, paying attention to reduction of stress or burden on caregivers, recognizing that there's also a gradual and stepwise loss of function common in patients, and that some patients their function may plateau after an illness and injury, and that if we can just really think about even the small ways that we can improve physical function, that can have a big investment in terms of maintaining the individual with more autonomy for longer. So it's a big payoff. So this is an example of, if you think about, many of us are in good health, and then when we have an illness, there may be an impact in terms of our functional impairment. And then through hospitalizations for older adults, people can get deconditioned easily, but there comes a point where there's a threshold where it really does become a disability. People can peak a little bit, especially with rehab, but then the decline can continue for some individuals requiring institutionalized care. What we also recognize is that as this is occurring, that the stress for family and caregivers often is at an increase. So let's go back to Martha. We know she's a 92-year-old. She was living alone prior to the fractured hip. There's some notation of some memory problems. We really don't know much about what that really means, other than a notation from the daughter. There was a decline in her ADLs following her hip fracture and hospitalization and rehab. The functional assessment, we really probably want to have more data in terms of her prior level of functioning at home. We probably want to have more information about her rehabilitation course in the nursing home, the hospital post-operative evaluations, and also a better assessment of the family supports in her environment. Again, the goals would be for safe discharge, independence at her highest level possible, and also looking at quality of life. And then also anticipation of problems. We know that there's a report of some memory decline. We really don't know what that means, but so having some cognitive testing might be appropriate in terms of really assessing for whether or not there's a mild cognitive impairment or dementia starting, or if it's just all these other losses that maybe it was her metabolism that was off. So in conclusion, geriatric assessment emphasizes functional assessment, functional status, and the goal of maximizing independence and quality of life. Loss of function is common, but small improvements can go a long way, and the recommendations really do need to be specific and targeted to the patient and family. Some of the challenges that we have found in our teams is that insurance is typically limited to maybe the neuropsychologist and the geriatrician. So we also need to think about how do we develop reimbursement models to cover the cost of the entire team. There's also limited opportunities in terms of our model to really assess the outcomes of the recommendation due to the funding constraints. We really don't have a mechanism to do that. We have anecdotal, but we don't have a mechanism to really look at that long term. And then also thinking about the different opportunities these challenges provide us. And for us, it's really been the partnerships we've developed with the educational programs through internships, through fellowships, with using our HRSA, our GEC project, the Finger Lakes Geriatric Education Project. We use monies from that to have faculty on the team as part of the faculty for the Geriatric Assessment Clinic. We also developed a geriatric assessment training module that is meant for healthcare professionals, and we have one that's focused specifically for social work. And I have the link up here. It's nptrainingworks.com/FLGEC, which is Finger Lakes Geriatric Education Center. And this has been really well received. It's a wonderful resource for you to use in training your students. We've used it with nurse practitioner students. We've used it some with medical students, not as much. Social work students, I had an assignment this semester for my students, and it really does walk students through using the different kinds of assessment tools that we use in geriatric assessment. So I think it's a wonderful tool that we're really grateful to be able to share with you. There's also some new educational models to prepare our next generation of competent interprofessional practitioners. And I sort of like this quote: the transformation in vision would enable opportunities for health profession students to engage in interactive learning with those outside their profession as a routine part of their education. And I understand that some of your programs might be doing some things with interprofessional training modules as well. We had something that we piloted this year with our MSW students where they're part of a interprofessional team that helped them really look at their teamwork, and it wasn't specific to healthcare, although there was healthcare members on that team. But I think this is still pretty novel in a lot of schools, and I know it's an area that we're wanting to pay more attention to and think it's really important. We're going to be piloting next year. We do a patient simulation, standardized patient simulation with our social work students that's based on sort of what medical schools do, but we'll be doing a nursing social work simulation, and we're launching 2 of those next year as a way to begin thinking about ways that we can have cross-training in terms of interprofessional teamwork. So in terms of thinking about fostering interprofessional collaborative practice, these are sort of the take-home points, I think. It needs to really be patient and family-centered, community and population-oriented, relationship-focused, and that's relationship among team members, relationship with how the team interfaces with the client and family. Process-oriented, it needs to be linked to learning activities, educational strategies, and behavioral assessments that are developmentally appropriate for the learner. It needs to be able to be integrated across learning continuums, sensitive to the systems in which we practice, and applicable across professions, so that we need to use language that's common and meaningful across professions. And again, outcome driven. I think we need to think about ways in which we are building some evidence that this is really the way that we need to move forward in terms of training. So those are my thoughts, and again in collaboration with my colleague Dr. Tom Caprio. And I do hope that the training modules that we've developed in geriatric assessment can be useful to you and your students as you move